Classical chest imaging of primary tuberculosis, presented by Dr. Jalamosen Udin, Associate Professor, National Institute of Diseases of Chest and Hospital, Dhaka. Introduction. Pulmonary tuberculosis, PTB, presents a diverse range of radiological findings that are crucial for diagnosis, management, and follow-up. The imaging features vary significantly depending on the patient's immune status and the stage of the disease, broadly categorized as I primary, II post-primary, or reactivation. Radiological features of primary pulmonary tuberculosis. In primary pulmonary tuberculosis, the initial focus of infection can be located anywhere within the lung and has nonspecific appearances, ranging from too small to be detectable to patchy areas of consolidation or even lobar consolidation. Figure 1. A, B, right paratracheal and hilar lymphadenopathy before and after treatment. A chest radiograph of a child who later was confirmed to have pulmonary TB demonstrates a right-sided lobulated cardiomediastinal margin with filling of the right hyalum, white arrows, consistent with right paratracheal and hilar lymphadenopathy. Figure 1a, b, continue. There is an oval density seen separately from the scapula in the right lung apex, red arrow, which in conjunction with the lymphadenopathy constitutes the Ghon complex. B, post-treatment chest radiograph demonstrates complete resolution of the parenchymal focus and lymphadenopathy with a normal right cardiomediastinal border. Radiological characteristics of primary pulmonary tuberculosis. Cavitation is uncommon in primary TB, seen only in 10–30% of cases. In most cases, the infection becomes localized, and a casating granuloma forms tuberculoma, which is known as a Ghon lesion, more common in mid and lower zones. This lesion usually eventually calcifies. Figure 2. The right middle lung zone shows a dense nodular opacity measuring about 10 millimeters, mostly referring to granuloma, larger black arrow. A calcified hilar lymph node on the same side measures about 5 millimeter, smaller black arrow. Mediastinal lymphadenopathy in primary tuberculosis. A striking finding, especially in children, is that of ipsilateral hilar and mediastinal paratracheal lymphadenopathy, usually right-sided. 5-3. This pattern is seen in over 90% of cases of childhood primary TB, but only 10–30% of adults. These nodes typically have low-density centers with rim enhancement on CT. Fig 4. Figure 3. Plain chest radiograph, posterior-anterior view. Red arrow showing right hilar tubercular lymphadenopathy. Fig 4. CT scan of chest with contrast in mediastinal view showing massive mediastinal lymphadenopathy due to tuberculosis with peripheral rim enhancement and bilateral pleural effusions. Occasionally, these nodes may be large enough to compress adjacent airways, resulting in distal atelectasis or obstructive pneumonia. Figure 5. Fig 5a-b. Chest imaging in a 2-year-old girl with pulmonary tuberculosis. A postero-anterior chest radiograph, CXR, shows pneumonia of the right upper lobe. Note the paratracheal lymphadenopathy. Bilateral CXR shows inferior bulging of the horizontal fissure and soft tissue density of lymphadenopathy. Fig 5c. Chest imaging in a 2-year-old girl with pulmonary tuberculosis. CA post-contrast axial computed tomography image, mediastinal window, demonstrates large volume lymphadenopathy of low density and peripherally enhancing lymph nodes, black arrow. The right upper lobe is expanded and of predominantly low density, consistent with caseous necrosis. Calcification of nodes is seen in 35% of cases. When a calcified node and a Ghon lesion are present, the combination is known as a Ranke complex. Fig 6. Fig 6. There is a combination of a calcified peripheral granuloma, black arrow, and a calcified hilar lymph node, white arrow, on the same side. Several other small calcified granulomas are seen in the right midlung field. Pleural effusion. Pleural effusions are more frequent in adults, seen in 30–40% of cases, whereas they are only present in 5–10% of pediatric cases, primary tuberculosis. Fig 7. Fig 7a. Pleuritis with pleural effusion are also the features of primary tuberculosis. A 12-year-old boy was referred to chest hospital because of pleural effusion without response to conventional antibiotics therapy. Fig, septini, B. There was no significant lung parenchyma involvement in the follow-up radiograph after 6-month anti-TB treatment. Pleural effusion culture yielded Mycobacterium tuberculosis despite negative smear results. His grandaunt was also diagnosed with pulmonary TB, miliary tuberculosis. Miliary tuberculosis is a disseminated form of tuberculosis that can occur during a primary infection as well as after reactivation of a latent infection. It's characterized by the widespread distribution of TB bacteria, often causing small millet seed-sized lesions in various organs, including the lungs. Fig 8. Fig 8. Chest radiograph postero-anterior view, A, and chest CT lung window, B, showing classical miliary pattern. The nodules, 2 mm evident in miliary tuberculosis, resemble the grains of a millet. There is homogeneous distribution of miliary shadow in all zones of both lung fields. Role of CT scan of chest in primary pulmonary tuberculosis. Computed tomography, CT, can provide more detailed information, especially in detecting subtle parenchymal lesions and assessing the extent of lymphadenopathy. Fig 4, which may show central low attenuation with peripheral enhancement. Fig 9. A 17-year-old girl had a routine chest radiograph A, which demonstrated a solitary pulmonary nodule in the left midzone arrow. CT lung window, axial plane B, confirms the presence of a 27 mm nodule in the lingula, arrow, with adjacent tiny satellite nodules, arrowheads, but no lymphadenopathy. Sputum smears were negative, but TB culture from bronchoalveolar lavage was positive for tuberculosis. Thank you all. Imaging. Classical chest imaging of primary tuberculosis. Learning pulmonology.